and also the degree of making the awareness level of making a misdiagnosis detected by the need to use immunohistochemistry with P16 and Ki67 among Mexican pathologists. No, it doesn't change. Okay. All diagnoses must be verified with biopsy prior to treatment. Biopsy is the standard gold or reference, as you all know. The intra and inter-observer variation in cervical biopsy is very well documented and is related in daily practice with overdiagnosis and upgrading of CIN. In 2002, Claes published one of the first and very good works in inter-observer variability with P16 immunohistochemistry to correct the inter-observer disagreement between pathologists. It corrected this error from 45 to 97%. All of these were experts. I'm going to show this work later. In 2006, I realized the first work in Mexico of this inter-observer variation agreement with similar results using P16. We corrected from 35% of agreement to 100%. Recent recommendations in the use of P16 immunohistochemistry in cervical biopsies routinely is limited because the experts recommend to do it just in difficult cases. How can we know if a case is difficult? Who defines it? The experience, the mood in which the observer is, the pressure from the clinician for a response according to colposcopy. Because of this variation is that the diagnosis of high and low grade in CIN was simplified in 2 instead of 3, the low, middle, and high dysplasia. But is still inter-observer variation very important? And the traditional criteria for diagnosis of CIN is in this lecture. The changes in the nuclei are high nuclear and cytoplasm ratio, hyperchromatism, pleomorphism, loss of polarity, and membrane nuclear irregularities. The mitotic activity, more mitosis in non-basal sites, and abnormal mitosis. The degree of differentiation is less than expected towards the surface, fewer and differentiated layers, and high nuclear density. In CIN, this is all mild, and the nuclei occupy in the microscopic field less than 60%. In CIN3, all thickness is affected, mitosis across the thickness, and the nuclei occupy the 80%. And CN2 is intermediate between the previous mentioned. The current criteria is that a deletion affects the 3/3 as expressed in this slide. You can see that the differentiation between CN1 and CN3 is that the nuclei are more pleomorphism and bigger than in CN1. This has very subjective manners. All depends on the mood that we go every day to work. This is the work that I mentioned in 202 that Claes realized and make with P16. This was the first work with P16. As you can see now, this is the concordance between the normal expected, the normal cases. There were just 71, CN1, 52%, CN2, 35, and CN3, 72. The agreement in all the biopsies were 71%, but in CIN were around 40%. This is a variation, and this is a very old work, but it's very illustrative when it's done. These 46 biopsies were seen in the same laboratory for a second time with another approach or with another clinical data. The original diagnosis was CN1 or 2. They changed to negative, just or metaplasia, 32%, and to CN3, 66.5%. These all are near 40%. So in the same laboratory, the same pathologists changed their original diagnosis in almost 40%. That is warrior. I did this first work in 60 Mexican pathologists in 204. P16 was very, it was not known at that time. Remember that the Claes work was in 2002. So what we found that the Mexican pathologists at that time weren't aware of making the same diagnosis and correct diagnosis. So can you see the inflammatory was almost the same and suggestive of BPH, CN1 almost the same, and CN3 and CN2 the same. The average of right diagnosis, a correct diagnosis at that time was 35%. And we did another research in our laboratory in 65 reference cases for a second opinion received for colposcopy, cytology, and biopsy. We found that the cases with no error were 12, so 16% had no error. Cytology error only was in 26, colposcopy in 12, cytology and colposcopy 9.3, and cytology, colposcopy, and biopsy were 20. The biopsy alone was 4%, and error in colposcopy and biopsy was 4%. So as you see, a lot of errors we detected in second opinion. The questions that the answer, that the biopsy answers without immunohistochemistry found in our work is that we can detect CIN or not in just 50% of the biopsies. Can we grade correctly CIN? From 17 to 50%. Is my diagnosis reproducible when another pathologist sees our slides? Is 50%. How productive is the lesion in CN1? This is very important because the productive lesion of CN1 is limited and is not a real dysplasia. How possible is that low-grade lesion can progress to high-grade lesion? This is answered right now with P16, but it was not at that time. What's the difference in the transformation zone? Remember that the transformation zone is acquired in adolescence. The normal epithelia, mature epithelia, has dendritic and Langerhans cells that trapped the virus and protect the epithelia from having the infection of papillomavirus. One observation from the work from San Francisco, California, he detected that the prevalence of human papillomavirus is more in the anus than in the cervix, a little more, but it's almost the same prevalence. So one question is, why don't we have, if the prevalence of papillomavirus in the anus region is the same or a little higher than in the cervix, why don't we have the same frequency of cancer in the anus? This is because these cells that trap the virus. The origin of the problem is the uncertain morphology with H&E. Cellular changes and their interpretation are not reproducible between pathologists. They are almost all the time overdiagnosed. This gives a false assurance to colposcopies that they are very good in diagnosing lesions. And there is also, in Mexico, a very typical pressure from the colposcopists that say, we have a very typical image, and the pathologists fear that if I don't diagnose CIN in this case, I will not longer receive biopsies from this gynecologist. There's also a PCR test positive that supports my diagnosis, and that takes away my responsibility. These cases are the presence, but not disease with BPH. This is a work from Boston. This is how they define or try to redefine the terms and the cervical intraepithelial neoplasia. And they try to separate which diseases are related to low risk and is expressed in this. So you can find that low and high risk are present in these lesions, but not in the high-grade lesions. In that ones, we just find high-grade risk virus. This is one picture of the this publication, and you can see that most of you are not pathologists. So you can see that this one cell was used to diagnose high-grade lesion. But when I showed this picture in meetings, all the pathologists said that this was just metaplasia. And as you can find here, this was diagnosis in this paper as high-grade squamous intraepithelial lesions. So when the pathologists want to know how to diagnose this, we find that this article can leads us to overdiagnose the lesions. That explains our findings. What are the simulators and distractors? General pathologists don't pay much attention to the type of epithelia from the origin of the lesions, or what are we looking at the microscope. Exor or endocervical thickness and differentiation of the transformation zone needs to be very well known. The associated changes, metaplasia and dysplasia, can coexist. One in major epithelium, and the other initiates atypia in different epithelium than normal. The coexistence, this is very important, of metaplasia with positive BPH test, health carrier, as I mentioned previously. This is a publication of 46 cases, 460 cases that we done with P16. As you can see, the original diagnosis was this one, and with P16, we changed from CN1 to metaplasia, from metaplasia to CN3, and the changes, this is how we change our diagnosis with P16. The statistics in this work were the following. Positive predictive value of H&E alone related to P16 was 0.56. And the negative predictive value was 0.59. So it's just as flipping a coin in the air. Sensitivity is 0.75 high, but specificity is 0.38. This is how they changed the diagnosis with P16 with the Kleist work. As you can see, in normal biopsies, they changed from 71 to 94. CN1 from 52 to 91. CN3 from 35 to 100. And CN3 from 72 to 99. And carcinoma, almost all. So they change from 45 to 96% using P16 alone. This is the first work that I showed to the Mexican pathologist. And these are the H&E images. So you can see that this is P16. And they said positive focal, positive diffuse. At that time, the work of Kleist had been published almost 2 years, and they didn't know how to use P16 at that time. This was published in Mexico, and fortunately, I received 2 awards for that. This work from a very well-known pathologist in the United States, they compared the diagnosis between consensus of experts and pathologists in the community in the same city. As you can see, the correlation between the community and expert pathologist or the consensus pathologist were in negative biopsies, 86%. In CN1, 61, CN2, 47, and adenocarcinoma in situ, 75. And they didn't agree also in cancer. So this is in almost all pathologists' laboratories, the disagreement. It's important that pathologists and gynecologists are aware that we have a diagnostic problem in the pathologist's laboratories. Know that there is a low agreement in the biopsies. It makes the difference between observing and treating, because high-grade lesions are almost treated all the time. With experts and educators on the subject, it has greater significance since errors are transmitted to subsequent generations. Generally, the error is overdiagnosis in a greater degree. If this is ignored, the overconfidence leads to overtreatment in the patients. The patients must know that colposcopy is not a definitive diagnosis and may vary, and that immunohistochemistry in biopsies should be required. This is the second inter-observer variation in Mexico. This was a prospective study done in 2017 in 67 pathologists, and we selected 3 cases with H&E in an immunohistochemistry with P16 and Ki67. We showed this immunohistochemistry slides at the same time with H&E. This is done 14 years after the use of immunohistochemistry in the cervix. Sufficient knowledge must have read and learn and how it should be interpreted, this immunohistochemistry. How do we selected the case in this? The most frequent is in the cervical biopsies is metaplasia and low-grade lesions and CIN or mid-dysplasia. Traditionally, also greater error in interpretation. Immature metaplasia is very common in cervical biopsy, and high-grade lesion has the least error, as I shown before. 1 case of metaplasia and 2 cases of CN1 covered this work. What's the object of this work? To know the agreement of aware of misdiagnosis between the pathologists in 3 cases. This means if they selected to read the immunohistochemistry at that time, is because they are not sure of their diagnosis. So this was taken into account for this work. This is the first case. This is a panoramic of all the fragments in the slide. As you can see, there's atypia. These nuclei are in all the layers of the epithelium, and it's clearly atypical the nuclei. Here is to compare with high-grade lesions. This is a detail of high-grade lesions. This is not the case. This is P16. As you can see, there's positivity in the lower third, and also in the cytoplasm and some nuclei. This is Ki67. This is has positivity in all layers, not all the cells, and just a few cells, and this confirms the CN1. This is a P16 of high-grade lesion to compare. How are the results? There are too many numbers here, but the correct diagnosis were just 32.8%. This is the whole group, and I'm going to show you the agreement in the whole group was 32% and kappa was 0.3. There were 10 experts in this work. How did they did it? Almost the same as the general pathologist. This is comparing the group, the experts and the pathology, and the group general pathologists did almost the same diagnosis, the same errors. So the awareness of this group in this case was 42%, almost less than half of the pathologists were aware that their diagnosis could be wrong. This is the second case. This was a metaplasia case. As you can see, well, it's a little confusing sometimes, the metaplasia, and this is what I call eosinophilic metaplasia, a work that I recently published. And this is low-grade lesion to compare, and this is a high-grade lesion to compare. As you can see, the nuclei don't have atypia, and they have a large cytoplasm, and the proportion of the blue that are the nuclei from the red, that is the cytoplasm, is less than 50% or 50% in this case, in these fields. What happens with P16? It's negative. So clearly shows that this is not a lesion. And when we use Ki67 for the proliferation, you see that the proliferation is only in basal cells, and most of the cells don't have Ki67 positivity. This is not a lesion, clearly not a lesion. What are the results? They did the correct diagnosis only the 37% of the pathologists. The kappa was 0.3, and the agreement was 32%. This is the expert diagnosis. They did it just in 50%. And the kappa was 40.47. And the diagnosis between the two groups are compared here. In metaplasia, the experts could diagnose better the metaplasia. So the error of awareness was 49.3%. The third case, low grade. As you can see, there are more blue than the red, and this is a low-grade lesion. Why? Because the nuclei don't have the higher degree of. With P16, as you can see, there is a positivity in the lower third and not in the highest or superior layers of the epithelia. And in some of the tissue, it's almost very few cells positive. You can see the atypia here is not clearly a high-grade lesion. What happens with Ki67? That not all the cells have the positivity. When it's a high-grade lesion, almost all the cells have to be in proliferative stage. How went the diagnosis? The correct diagnosis was 49%. As you can see, the agreement was 49% and kappa 0.41. What happened with the expert group? The diagnosis 70%. The agreement was 70% at the kappa 0.65. They did it better than the general pathologist. In the case 3, as in the others ones, the 33 that said that they need immunohistochemistry were this percent. If in these 33 pathologists, they had the initial diagnosis correct just in 25%, and they changed to correct diagnosis 48% and changed to wrong 22%. So this is confusing how the pathologists interpreted P16 and Ki67. These are resuming the 3 cases, and the average was 39.5% of agreement. The expert cases was 53% of agreement. 17% of average on those who decided not to use had the wrong diagnosis. Less than 25% on average changed their diagnosis to correct with immunohistochemistry. 60 to 70% knowledge of how to use the immunohistochemistry is inadequate even among experts. If the literature is not recommending to use on daily basis, and they say that be limited to problem cases, who defines what's a problem case? Since 75% of those who did not use it had a wrong diagnosis. Only the frequency use of correlation with immunohistochemistry and H&E in biopsies is a systematic way to allow to correct the diagnosis. This is the learning curve known everywhere. Results of the error in the colposcopy clinic. 60% of error in biopsy compromises the correlation with the colposcopy findings. The false sense of security that the colposcopists are, since we are overdiagnosing the cases, they feel that they have the correct diagnosis in colposcopy, and overdiagnosis of high-grade lesions is almost done most of the time. This overdiagnosis of high-grade lesions means that these women are always treated. CIN2 is considered a high-grade lesion, and it's known to have regression similar rate to CN1, and it always be a problem to discuss. What does it mean, the colposcopy clinic in Mexico? How many biopsies can we take? This is a very conservative approach. 10 biopsies in 35 states in Mexico for 35 in a year gives this number of biopsies. That means that this number is 68,000 erroneous biopsies with low-grade lesion. At 10,000 pesos, the global cost of treatment gives us 6,008,000 pesos. And this is very conservative figures. The procedure is very cheap in Mexico, and these figures allow to follow up costs and new tests that have to be done, that this has to be added to that in the previous cost discussed. There's a major harm in young people and also non-pregnant women. As you know, 15% of the women overtreated can have abortion or ending at before the 36th week of birth. And there's also an emotional and family damage in the diagnosis of high-grade lesions. To conclude, the awareness of having an error in the diagnosis of cervical biopsy is very low. Publications on using P16 and Ki67 in immunohistochemistry don't recommend to use it routinely, but as you know, it's well established that the agreement with H&E among experts is disappointing. Even so, recently guidelines still only recommend to use it in cases of doubt and in cases of high-grade lesions. I don't share that point of view in the literature based in the results shown. Thanks for attending the lecture. This is the way you can contact me. This is my name and hotmail.com. Thank you very much.
Thank you, Dr. Jose, for your valuable presentation. That was a wonderful presentation. So any questions for Dr. Jose?